afternoon, and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. The speakers and planners have disclosed no relevant financial relationships with any commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually, we have a sign-in link for you to click on, and if you have a question, please enter it into the Q&A chat. Also, a link to the event survey will be shared at the end of the program. It is my pleasure to introduce our guest speaker, Dr. Strike. He is a third-year internal medicine resident here at Northeast Georgia Medical Center. He is from Cleveland, Tennessee. He attended medical school at the University of Pikeville, Kentucky College of Osteopathic Medicine, and after completing his internal medicine training, he will be starting a fellowship at University of Penn State for pulmonary and critical care medicine. Join me in welcoming Dr. Strike.
All right. Thank you guys so much for coming. So the title of my presentation is Life After the ICU, Post-Intensive Care Syndrome. I chose this topic both because I hope to be practicing as an intensivist after completing my fellowship training, but also out of a lot of the experience that I had here at Northeast Georgia. I feel like it was definitely to my benefit that our ICU training is very focused on ICU liberation, and that's something that gets ingrained to us very early. At the same time, I didn't necessarily have a good understanding of post-intensive care syndrome and its relationship to that bundle. So hopefully for my internal medicine trainees in the room, this will be beneficial and maybe give some context as to why we do some of the things that we do here in the ICU. I have no conflicts, no interest to disclose. And here are my learning objectives. So we're going to spend a lot of the conversation talking about introducing post-intensive care syndrome and talking about its key features. We'll talk about our current recommendations for management, which again, a lot of our internal medicine trainees are going to be pretty familiar with. And then we'll talk about some future directions, some exciting developments now that we're approaching over 15 years of this syndrome being documented in the literature. And our story starts on a high note. The reason that we have been able to observe this phenomenon is because there has been a pretty dramatic improvement in survival from critical illness. Since the 1980s, all hospital mortality has decreased by 30%. This coupled with an increase in discharges to places like skilled nursing facilities, also an ever-aging population, unfortunately increased frailty, has led to this observed phenomenon where there's a recognition of impairments that affect multiple aspects of an individual's life long after the ICU discharge and after their acute critical illness had resolved. In 2010, the Society of Critical Care Medicine put together a task force meeting to discuss this. This was a multidisciplinary group involving physicians of multiple subspecialties, involving nursing, involving respiratory therapists, involving psychologists, behavioral health experts. And they agreed on the definition of post-intensive care syndrome. So this is when it was documented in the literature. This was created as a diagnosis to describe any new or worsening impairments in physical, cognitive, or mental health status after the patient has experienced a resolved critical illness. And here's a good outline on what post-intensive care syndrome looks like today. You'll see the three sort of main pillars, the three facets that we'll be talking about during this presentation for post-intensive care syndrome. That's the mental health aspect, cognitive impairments, and then physical impairments as well. Since that 2010 task force meeting, the definition has also expanded to include family. So unfortunately, up to 50% of patients who survive their ICU stay rely on long-term family caregiving support. And up to 40% of those patients that were previously employed will no longer re-enter the workforce. So on top of, obviously, the emotional burden of helping a family member through something like this, there is a financial aspect as well. And that's definitely something that the healthcare system should be aware of. The next few slides, I'm including patient testimonials. These quotes are from the Critical Illness, Brain Dysfunction, and Survivorship Center. It's an excellent online resource that has documented a lot of these testimonials from patients and also helps us keep track of ongoing and further research for post-intensive care syndrome. I highly encourage anyone that's taking care of critically ill patients to dive in, go online, and see some of these testimonies. It's very emotionally impactful to hear patients describe their journey with this in their own words. And it's really interesting to see almost the sense of relief that they experience when they learn that this is a documented syndrome, when they learn that other people are experiencing the things that they've experienced after their critical illness had resolved. So again, if anybody is taking care of ICU patients, would highly recommend that you go online and go through some of those interview style formats. The first one here, I had septic shock 4 years ago from urosepsis, and I'm in my 50s. I'm writing because I have never felt like myself again. I can't think clearly, my memory has suffered, and I am fatigued like never before. Before sepsis, I was active, hiking, biking, and rock climbing, and running, and now I'm sedentary. So this patient is probably experiencing a mix of both physical impairments associated with post-intensive care syndrome, and it sounds like the cognitive component as well. Here's another one. When I returned to work, the work I did before seemed foreign and unfamiliar. I became isolated and excluded from everyone. No one wanted to be around me. My wife of more than 36 years told me that I was just feeling sorry for myself and that I just needed to get on with my life. I nearly ended my life a few times. My family believed that I was just faking it all. So again, this is the mental illness aspect of post-intensive care syndrome. We're going to talk about some of the major risk factors that are associated with patients experiencing such severe symptoms once they get home. But unfortunately, this is not an uncommon occurrence. And then finally, I thought this one was particularly interesting. I'm a family doctor with over 30 years of experience. I have seen my share of very sick people. I personally was unaware of post-septic cognitive deficits until I had prolonged, greater than days, sepsis from an undiscovered prostate abscess. After everything was under control, I went home for 6 weeks of IV antibiotics, and I could not read, concentrate on TV, or even complete my application for my next round of family practice boards. The deficit was quite severe and lasted about 2 months with no permanent residual, I think. So I think this is a great example to highlight that we know there are risk factors with post-intensive care syndrome, specifically the cognitive component of post-intensive care syndrome, but it is also a pretty non-discriminatory disease. Any of our patients can experience this. This particular patient obviously has his faculties about him, is very much accomplished as far as a cognitive component, working in medicine, working as a family physician. But unfortunately, he still suffered from cognitive deficits associated with post-intensive care syndrome. So here's a good list of risk factors. As far as our non-modifiables, again, age and frailty are associated, disability, baseline cognitive impairment, baseline mental health disorders. I once had an attending kind of describe this as you're walking into ICU with whatever you have in the bank. Whatever you have as far as your cognitive abilities, whatever you have as far as your physical abilities, that's what you're coming in with. And if you're coming in at a disadvantage already, you are at increased risk of losing abilities to do things you were doing before. Certain pathologies associated with ICU stays, things like ARDS and sepsis. We'll also talk about some specifics involving those two, but also are non-modifiable risk factors, unfortunately, that are associated with post-intensive care syndrome. Potentially modifiable is specifically length of mechanical ventilation in some of our approaches. ICU length of stay is a big one. Presence of shock, presence of hypoxia, and then presence of multiple organ failure. And then our modifiables, things that, again, if you're aware of the ICU liberation bundle, may seem familiar to you. Things like particular sedation use, avoiding things like benzodiazepines, delirium. We're going to talk about delirium pretty extensively during this conversation. Delirium seems to be the risk factor that bleeds into every aspect of this, and multiple studies that we'll talk about are showing an association with experiencing delirium and post-intensive care syndrome, and even the degree and the length of delirium you experience increasing your risk of post-intensive care syndrome. Things like immobility, especially associated with ICU-acquired weakness, sleep disturbances, hyperglycemia, and then negative memories of the ICU, which is also something we're going to talk about pretty extensively in the mental health portion. For epidemiology, so it's estimated that greater than 50% will suffer from at least one component of post-intensive care syndrome, again, being the cognitive, mental health, and physical dysfunction. And each of these three domains have their own specific disease courses. And since the definition was created in 2010, there has been a body of literature both in trying to identify these risk factors and better control them. One of these of note is the brain ICU study. This was a study that was completed in 2013. It really helped lay the foundation for further parsing out the cognitive component of post-intensive care syndrome. Unfortunately, cognitive deficits after critical illness have been reported in 15 to 25% of survivors in multiple pieces of literature. This study in particular looked at 821 ICU patients that had respiratory failure or shock. They were assessed with something called the repeatable battery for the assessment of neuropsychological status, which is just one of these screening tools that's used at 3 and 12 months. And one thing I want to stress is that only 6% of these patients had any identifiable cognitive impairment at baseline before their ICU stay. So again, this was a prospective multi-center cohort study, and it was done across 5 academic medical centers. They were looking at adults admitted to the ICU, both medical or surgical ICUs, and all of these patients were mechanically ventilated for acute respiratory failure or shock. And the findings were pretty alarming. 74% of survivors had a cognitive impairment at 3 months post-discharge, based on that previously discussed questionnaire. 34% had an impairment similar to mild Alzheimer's disease, and 24% had an impairment comparable to traumatic brain injury. At the 12-month follow-up, cognitive impairment persisted up to 60%. And again, as far as risk factors, the glaring concern was delirium. Every additional day of delirium had an increased risk of the cognitive impairment in post-intensive care syndrome. There was also an association with hypoxemia and sedative use. What we'll talk about later is particularly benzodiazepines, if you're on continuous, something like a Versed drip, that increase your risk of experiencing delirium, which likely is the etiology of its contribution. Following up, just again, trying to get more points of data, trying to understand better what is happening that's leading to this cognitive impairment. De Azevedo et al. In 2017, they looked to see if ventilatory status had any implications. Again, the brain ICU study was looking at all ventilated patients. This was done as another prospective cohort study. It included unselected ICU patients, and they were looking at both ventilated and non-ventilated. And then once again, with very similar questionnaire tools, we're looking at cognitive function at 6 and 12 months post-ICU discharge. And what they found is that the ventilator was not the answer. Both ventilated and non-ventilated patients exhibited cognitive impairments at 6 and 12 months. What they were able to find on post-analysis was factors such as age, severity of illness, length of ICU stay were associated with cognitive decline. Again, these statistical analyses were performed trying to identify differences in the groups. Even among these, there really wasn't much of a difference. So why does this happen? The pathophysiology of the cognitive impairment in PICS is not entirely understood. There are multiple proposed mechanisms. So in critical illness, you're going to have this release, this remarkable release of pro-inflammatory cytokines like your IL-1, IL-6, and TNF-alpha. These inflammatory markers can cross the blood-brain barrier. And this can result in overactivation of microglia. You can think of microglia as the resident macrophages of the nervous system. That prolonged inflammatory state is believed to be the primary mechanism that's causing this cognitive impairment. Of note, MRI studies of post-intensive care syndrome survivors do often show global atrophy. There are also certain studies that point at potential hippocampal atrophy as well, which would affect things like higher order thinking, cognitive function, learning new skills, interpreting data, things like that. Again, this is an ongoing area of research. So changing tracks now to physical debility. Physical debility can result both from the critical illness itself and then the medical treatments that we give to those who are critically ill. The literature talks about focusing on a spectrum of disability to kind of help prognosticate outcomes involving how debilitated the patient will be at discharge. Again, this concept of whatever you have in the bank is what you're coming in with in the ICU. For high-functioning patients, it's expected to have good recovery potential. For older patients with comorbidities, standard comorbidities in relation to age, you can expect moderate recovery challenges. You can expect things like prolonged rehabilitation stays. You can expect things like cognitive impairment when they get home. And then for chronic and elderly patients, ICU care likely will lead to further disability. And that should be part of the conversation when we're talking with the patient, talking with family members. Looking at lung function, pulmonary effects of post-intensive care syndrome have been well documented as well, with a pretty strong association with ARDS, prolonged mechanical ventilation, and then lung infections as well. This is a ventilator-associated sort of contributory factor for functional disability. There was a study done in 2011, done by Harridge et al., that wanted to see the functional disability and quality of life in ARDS survivors 5 years after ICU discharge. This was done in the UK with 109 ARDS survivors, and they were looking most notably at 5 years post-ICU discharge they still had some follow-ups at 3-month and 1-year intervals respectively. They used something called the Functional Independence Measure and the Short Form 36 Health Survey. This survey I thought was pretty interesting. Here's a slice of it. It touches on all of the facets that would contribute to how well you do in your activities of daily living at home. So one example question, compared to 1 year ago, how would you rate your health in general? So that's a very subjective report from the patient. And then everything from vigorous activity such as exercise, participating in sports, down to carrying groceries or walking up a couple flights of stairs. This was kind of the gambit that this health questionnaire that's also used in some papers down the line was looking at. And what they found was at 5 years, 77% of survivors did achieve full functional independence. However, their physical component scores of that short form 36 did remain below population norms. So there is a persistent physical impairment that's there. This particular study did show that mental component scores did improve over time and did approach but never quite reach population norms by 5 years. And again, arguably the most concerning finding of this, only 49% of survivors had returned to work by 5 years post-discharge. So whether it is a mental component, whether it is a cognitive component, whether it is physical debility, for some reason they are still having significant difficulty getting back to the life they had, going back to the jobs that they had. So again, this conclusion, while the majority of ARDS survivors do regain functional independence, there are significant physical impairments. And then again, this study actually looked pretty favorably on the mental health portion, that there was a recovery that was appreciated. There are also anatomical changes that you can see in ARDS that can be longstanding. I imagine it wouldn't be terribly uncommon after the pandemic for many of us here to open up a recent chest CT and see some sort of permanent scarring, see some sort of permanent changes that could be traced back to critical illness a couple years back. These findings are often reticular changes, ground glass opacities, and then findings consistent with pulmonary fibrosis. There are multiple proposed links looking at PEEP levels in relationship, doing that lung protective ventilation that we've been aware of since the early 2000s, and then how much oxygen they were actually requiring. This was a paper by Sturgill et al. That was put in Scientific Reports in Nature, and it was actually comparing COVID-19 related ARDS to those with ARDS from other etiologies. It was another prospective cohort study. They were looking at pulmonary function tests to evaluate lung capacity and function. They were also looking at a 6-minute walk test to look at exercise capability. And then again, the SF-36 showed back up, and then something called the Hospital Anxiety and Depression Scale. So this was a very holistic review as far as how the patients are doing. And all this was looking at 12 months post-hospital discharge. And what they found is that both groups exhibited reduced lung function at 12 months, typically restrictive patterns on their PFTs. No significant difference between COVID-19 ARDS and ARDS from another etiology. The 6-minute walk test distance were both below predicted values. indicating persistent exercise limitations. And again, the PFTs were consistent with CT imaging that was also repeated. Another part of the conversation as far as respiratory effects after ICU patients can get home is that unfortunately many of them develop new chronic respiratory failure. Unfortunately, some of them require long-term ventilation with something like a tracheostomy placed in. The overall mortality for these patients is alarmingly high, reaching up to 52% within 1 year of hospitalization. If you look at the 5-year survival rates of those that require long-term acute care management for chronic ventilation, that 5-year survival rate approaches closer to 20%. And then again, chronic neurological diseases, presence of skin breakdown are other risk factors that contribute to the mortality in those patients. Aside from pulmonary, there is also just a generalized weakness that's appreciated in these patients. It now has the umbrella term of ICU-acquired weakness, which sort of covers both critical illness myopathy and critical illness polyneuropathy. Critical illness myopathy is acquired muscle destruction, primarily affecting muscle fibers, especially your type 2, your fast twitch fibers. This can be done from wasting. There is an association with that inflammatory state as well. Increased inflammatory markers lead to catabolic effects that leads to muscle breakdown, and decreased protein synthesis to help build new muscle. Typically, the skeletal muscle that gets affected, it's mostly in the proximal muscles. So you can appreciate patients having difficulty with tasks like going from sitting to standing in critical illness myopathy. Unfortunately, some of these deficits are permanent. There is, of course, rehabilitation programs. There's rehabilitation hospitals that have focused on the nuances of this, but being able to achieve full functional status again is unfortunately not always possible. Critical illness polyneuropathy is axonal neuropathy involving both motor and sensory nerves, so they can get paresthesias from this and actually loss of sensation as well. Very similar etiology in that this pro-inflammatory state ends up causing demyelination of these nerves. Once again, unfortunately, these deficits can be permanent. As far as risk factors, hyperglycemia I thought was fairly interesting. There's multiple papers both in bench research and then looking at patient outcomes that associates hyperglycemia with this ICU-acquired weakness. The idea is that hyperglycemia can actually activate caspase-3. It's one of the executioner proteases that gets talked about that actually lead to further apoptosis, causing skeletal muscle atrophy. And then it can also increase free radical production that damages mitochondrial DNA and can impair nerve production and repair in itself as well. As far as corticosteroid use, very conflicting evidence on what I read. Honestly, some folks will make an argument that the corticosteroid effect is primarily driven by hyperglycemia as a secondary outcome of corticosteroid use. But the literature is not confident on whether or not it is a true risk factor or not. So moving to mental health. Unfortunately, there is a high incidence of mental health disorders in post-intensive care syndrome. 37% of patients will experience depression, 40% suffer from anxiety, and then 22% meet criteria for PTSD. ICU survivors often have untreated mental health conditions, again, what you came with in the bank, that get exacerbated during their ICU stay. Of the three, I feel like this has the most interesting course in that there is such a strong association with negative emotional responses, negative memories and experiences from the ICU that exacerbates these depression, anxiety, and PTSD symptoms. I have a dear friend who spent 45 days in the ICU after an aortic dissection. He had to go through long-standing rehabilitation. He had vasopressor-induced ischemia and lost some digits in his feet. And he still is not at the baseline that he was at before. But none of that still bothers him. What bothers him still, and what he still has to get help from and support from family and friends from, is the memories that he had while he was acutely delirious and hallucinating in the ICU. He had these very detailed hallucinations that family members were actually wishing harm on him and turning on him, that things like catheter placement, line placements that were part of his treatment plan were actually physical attacks on him. He didn't know where he was. He didn't know what year it was. Those are the things, if you ask him what is the thing from that harrowing experience that he is still dealing with the most, that is what he talks about. And unfortunately, many patients have a very similar story. On that website that I discussed earlier, you can find an interview with a patient who actually was a leukemia survivor. And she said she would rather go through chemotherapy again than the hallucinations and delirium that she was experiencing while in the ICU. So again, delirium unfortunately bleeds into every component of this. Anything we can do to minimize that is going to lead to better outcomes. Here was a study that looked at a systematic review and meta-analysis of depressive symptoms. It was using something called the HADS-D, which is a 7-question scoring system for depression symptoms, not dissimilar to other scoring systems that we may use in the primary care clinic. Normal would be a 0 to 7, and then anything greater than 8 would indicate depressive symptoms. What they found is at 2 to 3 months post-discharge, 29% of patients were experiencing depression symptoms based off of that scale. 6 months post-discharge, 34%. And then unfortunately, 12 to 14%, 29%. So we're not seeing a good trend here, unfortunately. This is something that is persistent. So we've had a good discussion on the 3 facets of post-intensive care syndrome. And thankfully, with all of this research, there's been a lot of recommendations and a lot of preventive strategies that, again, should seem pretty familiar to those who have rotated at the ICU here in Northeast Georgia. Part of that is regularly assessing pain and providing multimodal analgesia to optimize comfort and recovery, to avoid, that avoids delirium in itself, managing pain. Implementing daily spontaneous awakening and breathing trials to reduce ventilator dependence. Again, the literature does show an association with length of ventilator time, not necessarily ventilator versus no ventilator. Use of smart sedation strategies, again, avoiding benzodiazepines to minimize delirium risk. To conduct routine delirium screenings, promote non-pharm interventions like reorientation, sleep hygiene, very important. Initiating early physical therapy and progressive mobilization, trying to kind of get the jump on this ICU-acquired weakness before it has the ability to really set in. And then involving families in care planning and providing education on patient recovery, both to enhance outcomes. And this turned into the ABCDEF bundle, the ICU Liberation Bundle. It touches on all facets of this. There's a physician by the name of Dr. Eugene Ely out of Vanderbilt that has really kind of spearheaded and become the face of advocating for this bundle that thankfully we do utilize here at Northeast Georgia. If you go on, again, that same ICU Liberation website I presented earlier, he has an excellent list of over 100 peer-reviewed articles that support the use of this bundle. They were out of very high-impact clinical journals, things like Lancet, JAMA, New England Journal of Medicine, and just has a lot of support behind it. What I didn't know before putting this presentation together was that there actually has been a very high-quality study looking at outcomes in using the bundle in its entirety, rather than just the sum of its parts. So this was published in Critical Care Medicine in 2019. So caring for critically ill patients with the ABCDEF bundle, results of the ICU Liberation Collaborative in over 15,000 adults. So this was a pretty remarkable study looking at over 15,000 adult ICU patients receiving care with the bundle. And they were looking at multiple metrics. So implementation of the bundle, measurement of outcomes such as ICU length of stay, ventilator-free days, and overall survival rates, and delirium. Again, things that we all now understand are associated with post-intensive care syndrome after discharge. And the outcomes were very positive. This bundle works. Higher adherence to the bundle was associated with 4 more ventilator-free days. So we're decreasing the length of stay, length of ventilator dependence. Reduced ICU stay by 1.6 days. Reduced overall hospital stay by 1.2 days. There also was a mortality benefit, 15.4% versus 21.4%. Patients managed with the bundle also had 25% lower odds of delirium compared to those who did not, which is huge. Early mobilization also led to 20% more patient achieving early mobility goals and improving functional outcomes post-ICU. So kind of looking beyond the bundle now, because again, this definition was created in 2010. And 15 years later, what are we looking at in the future? What maybe is not standard of care yet, but could be in the next few years? The most exciting development that I saw was the creation of these post-ICU clinics. Certain larger tertiary quaternary care institutions have started these clinics just to help give more longitudinal care to patients who are suffering from post-intensive care syndrome. The proposed benefits, they improve patient recovery and functional status. They hope to reinforce, again, longitudinal outcomes. They hope to address complex needs through a multidisciplinary approach, so involving things like pulmonologists and intensivists, pharmacists, physical therapists, behavioral health experts, and nursing staff. And also, again, help support the caregivers, who we also know when they get home, there's a huge time, emotional, and financial burden associated with these patients as well. This was from a very interesting read. It was put out in 2023 in Chest. It's an article kind of outlining the current literature on post-ICU clinics, and then also taking a bit of a narrative approach, talking about, well, here's how we did it here. Here's the decisions that we made. Here's why we made those decisions. And here's some things that hopefully the literature will support or later give us guidance on what to correct. And they put in this mnemonic called the importance mnemonic. And this is kind of the roadmap for those first few visits in the post-intensive care clinic. So the first is debriefing, making sure the patient is understanding and aware of why they were in the ICU, understanding of what happened, why certain interventions were done. Reviewing medications. One of the identifiable risk factors for both cognitive impairments and the mental illness component of PICS is actually the inappropriate continuation of medications. So while in delirium, we're aware that there are many medicines that we start mainly for their sedative effect in hopes of decreasing hyperactive delirium. Sometimes those medications get continued, and they get continued inappropriately. And the detriments from those medicines do not outweigh the benefits in those particular patients. So a good med reconciliation is a major part of these clinics. Evaluating post-intensive care syndrome in this paradigm that we've already talked about, in kind of the three pillars. Following up with any sort of organ failures during ICU and their resolution. So if they had something like a septic cardiomyopathy, making sure that we have clinical markers that are showing that there's been improvement. If they had something like an acute kidney injury, making sure that we're getting to see that to resolution as well. Following up with any referrals that are needed. So do they need physical therapy? Do they need occupational therapy? Do they need home health? Any other subspecialists that weren't continued or fell through the cracks at the time of the hospital discharge, especially for those that have, upwards of months of ICU and hospital stay. Following up with testing, addressing goals of care, given the new functional status. That may be a conversation that the patient has with family members or reviews on themselves and then decide that they want their care plan to look differently. Any sort of needs assessment, and then again, trying to lift any sort of burden however we can on the caregivers that are now taking care of many of these patients. And then here's another outline that just looks at all the different parts in the multidisciplinary approach to their follow-up clinic. Again, it takes a village, both physicians, behavioral health experts, nursing staff, physiotherapists. Diet, I would say particularly the most interesting ongoing research is diet in post-intensive care syndrome, focusing on things like high protein, limiting simple carbohydrates in association with their physical therapy regimen. Unfortunately, as of right now, there is not a body of evidence that can have us confidently saying that a post-intensive care syndrome clinic is gold standard. The initial research is promising and it's ongoing, but many large institutions have decided to be early adopters. Looking online, you can find these are some facilities that currently have or are designing post-ICU clinics. You can see Geisinger there. You can see University of Kentucky here in the Southeast, Penn State and UPMC also, Wake Forest here in North Carolina, and then IU Health as well. And again, this list is ever expanding because there are many folks that are very excited by the preliminary research and want to kind of be early adopters, want their institution to see if this can really help out this very vulnerable patient population. That's all I have. I have questions. Do we want to do questions before, my questions before these questions, or these questions then my questions?
Let's do your questions, and then we'll do questions.
Awesome. Questions then questions. So question number 1. A 63-year-old woman is discharged from the ICU following a severe episode of ARDS. She was ventilated for 10 days and required high levels of sedation. 3 months after discharge, she reports persistent fatigue, weakness, and difficulty concentrating. She is unable to perform her usual daily activities and has been withdrawn from family interactions. The family is concerned about her mental health and seeks your advice on appropriate management. What are we thinking?
What do you think?
I think I heard whispers.
I didn't hear.
Oh.
C? We're going C.
Okay. Yes, so early mobilization during the ICU stay. So this is something that's an ingrained part of our ABCDEF bundle while they're still in the ICU, while they're receiving our care. And again, to our credit, is something that the ICU here at Northeast Georgia is very passionate about. So again, not anything that should be unfamiliar to us. Question 2. A 64-year-old male is discharged from the ICU after a prolonged stay for ARDS due to COVID-19 pneumonia. He required mechanical ventilation for 18 days and was treated with high levels of PEEP. 3 months post-discharge, he reports persistent shortness of breath, difficulty walking even short distances, and fatigue. Pulmonary function tests reveal restrictive lung disease, and a CT chest shows ground glass opacities in a reticular pattern. His exercise tolerance is limited, and he's unable to resume his prior activity levels. So which of the following is the most likely cause of the patient's symptoms, and what is the most appropriate intervention?
I'm going to have to phone a friend. B?
Absolutely, yes. So again, we can have these longstanding changes in folks with pulmonary pathology in the ICU, and would absolutely be an appropriate candidate for pulmonary rehabilitation. Okay, and here are my references.
That's a great presentation. Thank you, Dr. Strike. Quick question is, what preliminary studies or research have you seen on these post-ICU clinics, and what are they testing when they look at these outcomes?
Yeah, absolutely. So again, the prelim data is positive. What they're looking at is hospital readmissions, which honestly the data has been middling on. We don't have a great answer whether it helps one way or the other. What we did see an improvement with was actually overall healthcare spending, which may initially seem counterintuitive with all the resources that these ICU clinics must involve. But the long-term downstream effects seem to be positive from a financial standpoint. And then also looking, so the main things, readmissions, overall healthcare costs, and then overall mortality. Honestly, the mortality data has also been fairly positive as well. Again, if I was a betting man, I think that maybe in the next 10, 15 years, you could see centers even like especially centers this size, having post-ICU clinics as well.
Hey, Drew, this was awesome. I really appreciated your presentation. It's just a comment because I feel like when we're treating patients in the ICU, we're so focused on getting them better and just getting them out, but we don't really do a good job of preparing the families for expectations and how they're gonna do maybe afterwards.
Yeah.
So this is like, puts it on my mind more to kind of, talk to the families more about the expectations of what's going on. So, thank you.
Yeah, absolutely. The probably the most impactful for me was looking at that chronic respiratory failure outcomes, and the folks that need chronic mechanical ventilation. Just some of those numbers are definitely something that I'm going to try to very empathetically incorporate into my goals of care discussions for those families.
Well done, Drew. That was an excellent presentation on a highly relevant but relatively unknown syndrome. And I think it's a good example in general for how to go about doing a grand rounds, the kind of a up-to-date literature review on a topic. So it's a good example. One area I've always had interest in is the reduction of delirium on the floors. And you kind of went over the approach in the ICU. Anything jump to mind in terms of like what can be applied to the floor that's applied in the ICU to help with delirium reduction?
Sure, absolutely. So as you're aware, our medical management of delirium is not great. The medications that we give often have more of a sedative effect that is beneficial in hyperactive delirium, but don't necessarily treat the root cause. So a lot of the behavioral modifications are things that absolutely can be incorporated. And again, things that I feel like our institution does well, brings up in rounds. I've brought up on our MTS rounds before on what we can do for delirium precautions. Some extra things that I haven't seen necessarily incorporated, things like sleep masks. Things that would have minimal financial skin in the game, but could lead to great improvement in something like sleep hygiene. So sleep masks, earplugs, things like that. That would be something I would be interested to see get incorporated both in the ICU and the floors.
Excellent. Any other questions or comments? Oh, here we go. Hold on.
Hey, Andrew, very good presentation. The topic is very good, actually. In the ICU, I think always been overlooked on this component. They are more like life-threatening things, but I think it's always worthwhile to take a look in that. But do you came across the timeline when the things happen, like after their post-intensive care, like what timeline we should be looking?
Timeline as far as intervention?
Yeah, in terms of the symptoms of psychological, I know like the myopathy and that's get like some time, but the psychological like delirium and other symptoms, like is it right after they come, or it is like can happen up to 6 months? Or
Sure, that's a great question. So and I think that's why a lot of the literature was looking at very particular intervals, things from 3 months up to 12 months, up to 15 months. Unfortunately, it's highly variable. And even in giving guidance to patients, it's both highly variable, and there's no guarantee that they ever return back to their baseline functional status in any of those facets. Again, it seems like the physical impairments, especially on the pulmonary side on that one study, do show an overall improvement, but never reaching full norms when compared to a age-controlled population. And then delirium, as far as like the cognitive impairments, unfortunately, some folks 12 to 14 months later will still be experiencing these symptoms. Some folks have greater recovery. I would say it's highly variable.
okay, thank you.
Very engaging presentation, Drew. One question related to your outcome you shown in relation to the intervention, that A, B, C, D, E, F, that when you show that and the intervention, and after that you show the outcome in length of stay. So I was wondering, like, if that was, what was that compared to in relation to, like, what was the total length of stay? I wonder, like, if that's, to see the context, was it 1.6 day reduction in comparison to 20 days, or was it just, I wonder if you happen to see that.
Sure, and full disclosure, one of the limitations of that study is there was a significant amount of variation in how they implemented the bundle. There was some heterogeneity there. But as far as overall outcome, it was a decrease compared to those that weren't having that implementation by 1.6.
I just have a quick question about, so most of the times patients from ICU get really discharged to the floor. Have you noticed, or have there been articles about whether early intervention with psych or behavioral health has shown inpatient intervention versus like waiting for them to get discharged from the hospital and then following up like a post-ICU clinic?
That's a really good question. That's not anything that I've seen. Again, everything in relation to the post-ICU clinic was very early involvement with them in that setting, after they had left. But that would be a really, really interesting kind of forward topic for research.
All right. Happy New Year. See y'all next week.